All right, he just proved that he's worthy of being on the panel.
Pressing the button. Come on.
So you're in for a real treat here, and so hopefully your postprandial sleepiness won't take away from the from your benefit from this. But we have 6 very expert, august individuals, and you can see their pictures up on the slide, and you've had their bios. So I wasn't going to go through in detail, and you're welcome to say more about yourself and your practice if you'd like. So the way we'd like to spend the next hour with you is to discuss 3 different topics that we're hearing from the patient community are really critical and commonly come up in the course of the patient journey. I'm going to show you some draft cases, and then we're going to have 2 people do the first comments, and the rest of the group will chime in. We'll spend about 20 minutes on each. We're not going to do questions in this portion because right after this, there'll be breakout sessions and you'll have the opportunity to speak with 1 or more of our experts during that time. So save your questions, write them down, and take advantage of the opportunity to meet with them after this session. So let's get started. Case number 1 is the topic of discussion is what happens when recurrence without an ALK resistance mutation. And of course, Alice highlighted some of that this morning in her presentation about the complexity of the different kinds of resistance mechanisms that can occur in an ALK lung cancer patient. So in this case, we're talking about a 60-year-old presenting with shortness of breath, cough, and fatigue. Sure, that sounds familiar to some of you. They went in and their doctor did a CT scan and confirmed that the patient had a lung mass. As appropriate, was biopsied and had adenocarcinoma of the lung. MRI of the brain showed no brain mets. Important. Molecular testing by NGS, let's say, was positive for an ALK rearrangement. Their physician's done everything right online, put them on an FDA-approved TKI. Patient did really well and was back to work. You know, our registry results show today that the majority of people who filled out the registry so far are back to work. So this hopefully is a very typical scenario. However, several years later, this 60-year-old individual developed worsening cough, shortness of breath, and bone pain. Imaging now showed multiple new lesions, lung and lymph nodes and bone. Biopsy confirmed that it wasn't histologic transformation, which is only can be determined by a biopsy, and that's why it's so important. One of the reasons why it's so important everybody gets a biopsy at progression. Molecular testing was the same profile as their original NGS, not showing any new mutations in the ALK gene. So the question for our panel is, now what do you do? Hoss.
Good morning, afternoon, sorry. I think, well, as you pointed out, unfortunately, common recurrence in the clinics, so it's not unusual. So one of the positive aspects of the trial is, or the case is that at the time of initial diagnosis, appropriate testing was done, translocation was found, appropriate therapy was started. So I think that's really good. At the time of recurrence, again, biopsy is important. I think we have to highlight that it is important to confirm that it is the same disease. And I think you want to do the molecular testing, and I'm completely aware of all the challenges that are associated with re-molecular testing, especially in the case of ALK, and hopefully we get to talk about that a little bit. So I think those are the good aspects of what we're seeing, that the care is being delivered according to what we would think would be standard of care options. So obviously, without having an obvious resistant mechanisms, it becomes a little bit difficult. My standard practice is to pick the next TKI where I think has the capacity to address any potential resistant mechanisms, even if we can't find, because the testing is not 100%, and we know that, so there's a possibility of having something there that's just not detected by the standard testing. And therefore I would pick another TKI where I think would have the opportunity to address any potential resistant mechanism. So.
So first, when I look at this case, I look at the time of progression. Is the patient symptomatic or asymptomatic? In this case, it's symptomatic. And then you look if it's local only versus multiple. In this case, it looks like more diffuse progression. And so I think that this would indicate to me that the next step would be a change in systemic therapy. I like the fact the patient had a biopsy and the NGS profile doesn't reveal a mechanism of resistance. That can sometimes guide our clinical trial decisions. And I think Dr. Shaw discussed this morning in other aspects. And I think in this situation, the main treatment option that comes to mind is lorlatinib, assuming that the person didn't get lorlatinib in the first line setting. I like to sort of continue ALK-directed therapy as long as possible. So that's probably what I would recommend. I will make a point, though, that chemotherapy still has a role in this. It has a certain stigma. And I talk to patients, I say, look, we don't have an obvious next therapy now, but chemotherapy can control your disease until we can get you on a trial. And I worry we've stigmatized the role of chemotherapy in treatment of lung cancer.
We want to downplay the role that chemo can play, definitely. And it can be a really good effective treatment option for many of our patients. Typically, though, I mean, I agree with you, the clinical trials would be a really good idea if we can find a resistant mechanism that necessarily addresses it. But in the absence of something, I guess we can get into the NGS a little bit. I mean, how many of you would just do a DNA, or would you rely on DNA and RNA? And because we know that with the addition of another level of testing, the possibility of finding something would be even higher than it would be based on just a DNA-based assay. So at least we try to get the DNA and RNA testing done. I know it takes a little bit of time for it to come back, but the details of how exactly I hope we can get to discuss.
Yeah, I think you bring up a really excellent point, Hoss. I mean, I think the devil's in the details when it says molecular testing, no differences from initial NGS profile. You have to dive into that a little bit more to really make sure that the appropriate comprehensive testing has been done. As Hoss suggested, there's differences between different panels that are sent, whether it's DNA-based versus RNA-based. RNA-based panels can find, fusions and other type of potential acquired resistance mutations or alterations. MET amplification also is a potential resistance mechanism in this case, occurring in about 15% of patients in this setting. And so it really is important to try to figure out whether or not those things were adequately assessed.
One other plug I'll make, I think all of us see a lot of second opinions, but when I talk to patients, if they're on a first line therapy that's appropriate, I tell them, go get your care in the community. It's going to be the same care. However, if you have disease progression, no matter the quantity or the nature of it, please come back, because I think this is where the nuances of managing ALK-positive lung cancer really come in. So if you just keep that in mind.
I'm just going to add a couple of very minor clinical points, which probably were not mentioned because they're very basic, and I'm sure this crowd already knows this. There's not a mention of brain scan. So there's a question about whether patients who don't have brain metastases, whether they should get surveillance, and there's a bit of a debate. I tend to do brain scans on a certain regular basis. But anytime there's a recurrence outside the brain, I will get a brain scan done to ensure that there is not a brain recurrence as well, because that potentially could influence your choice or may influence whether you're going to continue the ALK TKI or not, especially if you're switching to chemotherapy. The other thing I would say is the biopsy site. There are occasions when you send for a biopsy and the biopsy done is of the most accessible site. It is very important that in a patient where there are certain sites that are progressing, that you try and biopsy a site that is progressing, because it is quite possible that if a site that is not progressing is biopsied, that may not show a molecular change or a mechanism of resistance, and may be only apparent on if you do a biopsy of a site that is progressing. And then the final point I was going to mention is that I completely agree if the patient was started on an ALK TKI other than lorlatinib, I would go to lorlatinib. But in the phase 1/2 trial of lorlatinib, and this was based on the blood NGS testing. This was not on tissue. So I want to emphasize that. But there was a difference in the efficacy of lorlatinib in the second line based on whether it was an ALK-based resistant mechanism. So if you remember what Dr. Shaw said, on target, all those mutations. If that was the mechanism of resistance, those patients tended to do better with second line or third line lorlatinib, whereas if it was not an ALK-dependent resistant mutation, the efficacy was not as good. Now, it was not zero, so there are patients who derive benefit. And again, I want to emphasize that this was on blood-based NGS testing, which may not detect in about 30% of the patients the molecular alteration that one could detect in the tissue. But there is a little bit of a difference possibly of what the second line, third line efficacy of lorlatinib is based on whether it is an ALK-dependent resistance mechanism or not.
So I agree with Dr. Gadgeel's first point about the importance of surveillance brain MRIs, and particularly when there is known progression in the body. If the status of the brain is not known, I would definitely advise to ask about a brain MRI or repeat brain MRI in that setting, because it does have very important implications for how you think about the next treatment. Going back to this case with the repeat biopsy, in this patient, in this case, the biopsy that was done was of a tumor. And with this biopsy, they were able to look at the histology, confirm that there was no transformation in the histology, and also get molecular testing done. If a liquid biopsy, meaning blood biopsy, was done and came back and you are told, oh, there wasn't anything that was seen on the blood biopsy, that is a very different story. And that is because we know that blood biopsies can be less sensitive than tumor biopsies, depending on how much shedding of tumor DNA there is in the bloodstream. And so if the blood biopsy picked up the known ALK fusion, but there were no other ALK mutations or other targetable alterations, then that is very distinct from if the blood biopsy came back completely blank. In that case, you cannot conclude that a reliable resistant biopsy was done and truly did not detect any resistance targetable alteration. So there, a consideration of a tumor biopsy is important. So I just wanted to highlight that interpretation of the result, depending on whether a blood biopsy was done or a tumor biopsy was done, is critical in using that to guide your treatment decision-making.
So I think to Dr. Stinchcombe's earlier comment, I think it's really important to think about the patient's symptoms. So this patient is now clearly symptomatic, worsening cough, dyspnea, and pain. And even when we're thinking about next line treatments, whether or not it's another ALK TKI or even chemotherapy, there are also other, specialists that play a really important role in the care of cancer patients, not just oncologists. So, I'm thinking about, does this patient need some radiation? How bad is this cough? How bad is this dyspnea? Is there any obstruction? Do we need to think about interventional pulmonology and getting a stent in, right? All these things can be done in the interim while you're looking for that biopsy, looking for the, mechanisms of resistance, but we shouldn't forget that. And I think in this situation too, chemotherapy may have a bigger role because, cytoreductive chemotherapy can often be more effective in a shorter period of time than sometimes our TKIs.
May I just add one more point? While we are all emphasizing that important value of repeat biopsy when cancer is progressing, I think it's also prudent to point out that not always is it right to wait for that biopsy and the result. So that I would like to relay that message. If there's a pretty fast-paced progression that's happening and you are having these worsening symptoms like shortness of breath, you are suddenly requiring, help of supplemental oxygen when you didn't before, there may be occasions where the treating doctor says, okay, you know what, the rate of the change is too fast. I do not think it is the right thing to do for you to just go for that biopsy and wait another couple of weeks for the result to come back. And there may be situations like that where the doctors advise that in the interim, to get that cancer under control, let's go ahead and try a dose of chemotherapy, right? Or let's go ahead and just empirically try switching to lorlatinib. So not always is it right to just wait for a biopsy to be scheduled and wait for that result to come back.
That's a really great point. So Shirish, when we were preparing for this, you had an opinion on the use of chemotherapy. If you could share that with the group, because that's obviously critical here.
Yeah, Ken and I know each other for a long time, and Ken knows that I think I have an opinion on a lot of things. And sometimes Ken and I don't have the same opinion about certain things. Anyway, no, I do think, and I'm certain this group is aware, particularly when it comes to pemetrexate, there's data to suggest that in these translocated, and there's more data with ALK patients, that there may be preferential efficacy of pemetrexate-based chemotherapy compared to other non-small cell lung cancer patients. Currently, I actually texted a patient who was not able to join us because he's fishing in Canada, and that was more important to him. That's a good thing. That's a good thing.
He just didn't want to be with you again.
Right, exactly. He's with me a bit too much, I think. Again, a case doesn't, I mean, this is just a case doesn't make data, and we all have anecdotes, but I'm just mentioning that he actually has had the longest control on chemo plus lorlatinib than he had with any of the prior ALK TKIs that he received. And this is now coming up to almost more than 3.5 years. And he has continued on chemotherapy. And the only reason I'm bringing up that case is that there is a sense sometimes I see that, oh, chemotherapy means it's the sort of the last option. And I don't think it should be viewed that way. Secondly, not everybody, and there are patients who have a hard time, but there are patients who particularly on pemetrexate can continue their life the way it was before they got started on pemetrexate. Now, there are patients who experience fatigue as you keep going, and have tried to modify, go to an every 4-week schedule, reduce the dose a little bit, eliminate the decadron, and there are ways to sort of try and keep the patient going on the Alimta. But the point is, for all the wonderful things Dr. Shaw discussed today, I think chemotherapy has a role, and more so in ALK patients than some of the other non-small cell lung cancer patients.
Thank you. So I made the following notes from what I think we just heard. First of all, you need a biopsy, and blood's not sufficient for in this setting. 2, chemotherapy could be a really good option, and it doesn't mean it's that it's the end of the line for you. And actually, it could work for years, as we've just heard. The brain scan in this setting is just as important, and I'm really glad when I made this, I left that out because it brought that point out really well. What Tom said really got my attention. I really like to highlight it with everybody. If you went and got a second opinion when you were diagnosed and treated, and now it's returned, go back and double check, because there's an art. This is what the last point, there's an art of medicine for caring for outpatients. You can't just go online and read what it says and think Shirish was just alluding to it. When do you change the dose? When do you change the drug? When do you add chemotherapy? These are things that take experience, and a lot of really great physicians out there have limited experience with ALK. So it's not a commentary on them. It's just the reality of the situation. And then the last thing, yeah. And then any last comment? Those were, didn't miss anything. Okay. So we're going to move on to a second case, and we're going to start with Shirish and Jess. We're going to talk a little bit. Oh, I got to keep it.
Jess and Shirish.
Oh, okay, in that order? Okay. Jesh? Can't have too many SHs in there. Okay.
Turning the mic on and speaking.
All right. Now we're going to talk about what happens if it recurs just in the brain. So here we have a 51-year-old with persistent cough, shortness of breath for 3 months. Probably sounds familiar to a number of you. Finally, after 3 months, goes in and has a chest X-ray. You can see the findings there. Biopsy revealed adenocarcinoma. MRI showed showed intracranial metastatic disease. I can't read it, so small there. Negative, sorry, negative for intracranial disease with an ALK rearrangement. So just like the other one, put on an ALK TKI and had a very nice, in this case, partial response. But then unfortunately, several years later, the patient comes back with intermittent headaches and of increasing intensity. Imaging reveals disease progression, no disease progression outside the central nervous system. The biopsy isn't feasible in this setting. Tumor mutation, blood circulating DNA is positive for the ALK rearrangement with no obvious changes. We've heard that's 30% of the time it could miss it. So now in this setting of isolated brain recurrence, what options do you see, Jess?
Thanks, Ken. So there's so much to discuss here. Let's start with assuming that the treatment that this patient was receiving was a second-generation ALK inhibitor, alectinib. Let's start there. So the first point I'll make is that this is an excellent example, again, going back to the point that Shirish was making earlier about doing surveillance brain MRIs, right? Even if your initial brain MRI was negative for brain metastasis, the goal of doing surveillance brain MRIs is to try and catch these brain metastases early when they occur before they grow to a point where they cause symptoms like headaches. And I think it's safe to say that when these brain metastases are caught early, often there can be more treatment options that may be better tolerated. So that's one point, is that the importance of surveillance brain metastasis. And even though the second generation ALK inhibitors like alectinib do get into the brain and do have activity in the brain, it's not perfect, right? We so often still see patients like what's presented here, where the body might be doing great, but there are new lesions coming up in the brain. Now, the second important point is, I'm assuming this patient had a brain MRI and it did confirm that there is new cancer in the brain. Then first question, is it causing symptoms or not? In this case, it is causing symptoms. And then the second important question is, what are the symptoms from? Is there just one spot that's pretty sizable and is causing headaches or other symptoms like weakness or numbness, tingling? Or are there multiple spots that are new and growing? And the reason I mention these things, like, are there symptoms? What's the distribution number of spots in the brain, is because that does have a great bearing in how we think about the treatment options. Dr. Angel Chin was mentioning earlier about how we pull in doctors from different disciplines in caring for patients who have ALK-positive lung cancer. And so in the context of brain metastasis, we often work with radiation specialists, right? Radiation oncologists. We often work with neurosurgeons as well as medical oncologists who specialize in cancer in the brain, called neuro-oncologists. And in this case, it's really important to come together as a team, review the imaging, look at the distribution of brain mets and decide which way is the best to go. Do we, for example, let's say there's one big spot in the brain. It's sizable, there's a lot of reactive swelling around it, and we know it's causing neurologic symptoms. We may even consider, is there a surgery that's required to try and take out that spot in the brain? We may work with radiation doctors to ask if it's one small spot, but it's definitely new and growing, should we go ahead and zap that spot? If the pill that you're taking is helping everywhere else, and there's just one spot in the brain that's escaping, sometimes we can treat that one spot with radiation with local therapy and continue the same ALK inhibitor and have you stay on that for quite some time without further change happening. The opposite scenario is if there are multiple spots that have cropped up. Sometimes we see these tiny spots, but scattered throughout the brain. And in instances like this, what you really need is a change in the medication itself. So as an example, if you were previously on a second generation ALK inhibitor like alectinib, we may consider switching to a third generation ALK inhibitor like lorlatinib, which we know gets into the brain space much better and can induce really durable, nice responses in the brain, exactly in scenarios like that, where there's multifocal progression in the brain on a second gen ALK inhibitor. And then the options change if you are already on lorlatinib and there's multifocal brain progression, then options change. And maybe I will stop there because I do not want to monopolize this discussion and hand over to Shirish and other panelists.
It's always difficult to add anything to what Jess has said, but a couple of thoughts. One is the site matters. And for us, broadly speaking, the brain is divided into kind of the anterior 2/3 and the posterior 2/3. One of the reasons why brain metastases are a concern is not just because brain being a critical organ, but our brain is within the skull. And so when anything starts growing, there's not much space there. And so what happens is when a tumor starts growing, it puts pressure on the remaining normal brain, and that can cause, that can impact critical brain function and can be even life-threatening. And that is much more likely to occur in the posterior third of the brain, what is called as the cerebellum, sometimes even brainstem. And when it comes to that, you want to take care of those brain metastases much more quickly. You want to take care of brain metastases quickly, but those brain metastases are even more critical and potentially could be life-threatening. And so we are much more inclined to use local treatments, be it radiation, surgery, to manage those patients. So the first point I would say is, it's not just the number, the size, but it also matters whether it's in the anterior 2/3 or posterior 2/3 of the brain. That posterior 2/3 of the brain is a lot more sort of compact area. There's very little space to go, and there are a lot of critical structures there that control very basic life needing, if I can say, functions of the body. Now, in general, metastases tend to occur much more in the front of the brain rather than in the back of the brain. So that is much less common. Another thing to remember is that we tend to nowadays, when we do use radiation, use the stereotactic radiosurgery because it doesn't have, generally is not associated with the adverse effects of whole brain radiation, which was a lot more commonly used in years past. And this is very critical in ALK patients where we hope they live for years together. And another feature of ALK patients is, for the most part, ALK patients are kind of in the prime of their life. They are working, and you want to retain cognitive function in all lung cancer patients. I want to be sure how I say this properly, but I do think the demographics of this population really requires that we pay attention to ensuring that we are, of course, you want to take care of critical issues first. And at that point, it's a matter of ensuring that you're urgently addressing it. But if you have the liberty that there is not such a pressing need, that you choose a treatment that doesn't have a long-term effect, and therefore there's a lot more focus on using SRS. Having said that, I will say with all these brain penetrant drugs we have, alectinib, lorlatinib, better than alectinib in terms of brain penetrance, I'm also somewhat cautious about recommending SRS. And that's because we are seeing more and more what is called as radiation necrosis cases. So patients who have had SRS, they're on these ALK-TKIs that are brain penetrant, and even up to 2-3 years later, you do a scan, patient has a headache, you see an increase, and really the discussion is this true tumor progression, or is this radiation necrosis? I mean, I remember a case on lorlatinib, this was almost 5-6 years ago, who underwent 2 craniotomies, and both of the times the group was convinced this is tumor progression, and underwent 2 craniotomies, and resected specimens just showed necrosis. And so again, one thing I want to say, if SRS is needed, even if whole brain is needed, there are cases where those treatments are needed. So I don't want to give you the impression that we should never do whole brain radiation or we should never do SRS. But there are long-term implications to the treatment choices we make, and it is very important. Finally, there are patients where there has been radiation done, patient is on ALK-TKI, and there is brain progression, and there is some data, extremely limited data, and I don't want to keep bringing in chemotherapy, where you add chemotherapy, probably including anti-VEGF therapy, and there is some benefit. And so there could be treatment options even after brain penetrant ALK-TKIs have been utilized.
A very quick point. In the instance that SRS that Shirish was mentioning too is used, extremely important in order to try and minimize that risk of radionecrosis to not overlap with these brain active ALK inhibitors. And so I think all of us in this panel make sure to hold the ALK inhibitor while someone's getting that radiation focal treatment. But I would say so often we still see patients where they were overlapped, and then definitely there's that radionecrosis with injury to the normal tissue where it can really complicate the brain MRI findings and management.
I think this highlights a point that's come up already, which is if you have brain metastases, I personally think it's a requirement that you make sure you have a good multidisciplinary team. And this includes potentially not just your radiation oncologist, but a good neurosurgery consult in case that is a good option, as Jess mentioned. But also, if possible, want to advocate for our neuro-oncology colleagues. These, if you may not be aware, these are our colleagues who specialize in patients with brain metastasis. And so they often have really great insights about, for instance, this question of, is this inflammation from radiation or is it true progression? But they also have great insights about potentially treatments to treat potential, for instance, radiation necrosis, whether it's with Avastin or steroids, or clinical trials for true brain progression.
We've talked about this a couple of times, so maybe we should bring this up. So we've talked about surveillance, CNS surveillance. You guys have a set rule as to how often you do your surveillances? Any specific?
I just say at least once a year.
At least once a year
Should
is,
Yeah.
So that's a good idea, but I want to know what else everybody is doing.
I'm just laughing because Haas loves to stir up controversy.
That's why we invited him.
Yeah.
Well, as the only Middle Easterner on this panel, it's my job to be. No.
To cause controversy, right? Yeah, I tend to do 6 months, but I have no problem about 1 year as well.
I think at least every year is a good rule. I tend to generally do at least every 6 to 9 months.
So I know Tom is there because I just whispered in his ear and that's what he said. So let me ask you one other question. So we talked about, let's say there's an isolated lesion. Let's say you do your neurosurgical intervention or stereotactic radiation, and then you are maintaining the same TKI, which has worked well and everything is good, right? How many episodes of CNS progression are you willing to tolerate before you say, despite the fact that systemically the disease is under control, maybe we should change the medication?
So first of all, Haas is taking over Ken's job. So I don't have one.
Can't do anything right today. I can't criticize.
I don't have one answer for that. And I think that's one of the messages you're hearing is that this is exactly why you want second opinions from other physicians, because everyone's story is so different and what's right for you will be different from what's right for another patient. I take into consideration what's the ALK inhibitor that you're on in terms of what are the next systemic therapy options. Are there like really good systemic therapy options that we could easily switch to? And also, what are the time intervals, right, to needing another round of local therapy? So if you had local therapy, meaning with either resection or radiation 5 years ago and did well for 5 years, and then one other spot popped up, that's a very different story from somebody who had one spot zapped, 6 months ago, even, let's say, and then has 1 or 2 more lesions that pop up. The more time that's passed since the local therapy before another spot coming up, the more comfort I have in considering repeating that local therapy approach. Memorial Sloan Kettering Group recently put together a retrospective series looking at outcome of patients who get these local therapies for what we call, I don't want to steal the thunder, oligoprogressive disease on these tyrosine kinase inhibitors. And what they found is that there's actually a good proportion of patients in whom that tends to be the behavior of their cancer, where they just tend to have, over the course of years, pulses of one spot showing up or a couple spots showing up. They do fine for a while after local therapy, and then another 1 or 2 spots coming up. And so often we can't really predict that initially. We can only see that in hindsight, right? So if we've treated somebody with SRS and they've done well for 2 years and then just 1 or a couple spots popped up, I would be much more inclined to consider another round of SRS there versus having to switch to another medication.
I think that just to bring it back to the case, though, one of the things that, again, is really important that jumps out to me for this case is the fact that this patient, again, is symptomatic. So I agree, while we would obviously not want radionecrosis to occur if we use SRS or not have to undergo a surgical resection, the fact is, again, with TKIs, it may take time for that intracranial control to occur. So if this patient is having headaches, I have very low threshold to get them on steroids and have them see neurosurgery and or radiation oncology ASAP. I think supportive care is something that we, I think sometimes we're so focused on our clinical trials and interventions, which are all obviously very important. We forget a little bit about the supportive care aspect of things, which just complements everything else we do. And just like the previous case, the patient with bone pain, they have bony metastases. In that situation, we should definitely think about a bone modifying agent. So a bisphosphonate or denosumab should definitely be considered for that patient for supportive care. In this situation, I think the question that Jess posed to Shirish wasn't really answered by us is, what if this patient was already on lorlatinib and now has developed intracranial progression, and whether or not that makes a difference if it's oligo, steal my thunder later, one site versus multiple sites. I think we all probably would agree that if this is a patient already on lorlatinib and there's a single site of CNS progression, we would want to do localized therapy and continue them on lorlatinib, especially in the setting of excellent extracranial progression. I don't know that I have a great answer for, if this patient has a lot more spots developed now that they're on lorlatinib, if there really is a right answer to this, and in terms of best treatment, and that I think with the multidisciplinary care is so important, I would be inclined to keep them on the lorlatinib and potentially add other therapies to it. But I would love to hear the group's response on this as well.
No, I just mentioned that, yeah, there are patients where you have done the radiation, sometimes even whole brain, and patient is on lorlatinib, tumors are progressing. They can be very difficult to treat. And occasionally I have tried systemic chemotherapy, continuing the ALK-TKI, and seen some stability. I don't know if I've seen responses. I'm talking about a couple of patients. Curious what others have done in these situations.
I mean, I think that, the impression is chemotherapy is not CNS penetrant because of the blood-brain barrier. But as one of our colleagues, Greg Helm-Karen always says, once patient has brain metastases, that blood-brain barrier is clearly no longer intact. And so, while we don't resort to chemotherapy for intracranial progression because we think about the systemic response is, 30-40%. And, what I say is you never want to take only a 30-40% chance with your brain. But when we're truly down to, more progression on lorlatinib, I agree that I think adding chemotherapy, there is a benefit to that, even in the brain.
This is not directly related to the case, but just to the general concept of CNS metastases. In ALK trials, at least patients with progressive asymptomatic brain metastases, those patients are allowed. But that's not true about all lung cancer trials. And I would really urge the patient advocacy group to encourage industry sponsors that such patients are allowed. There has been this historical thing about, I can understand not excluding patients of symptomatic brain progression because those patients could have other symptoms that may limit their ability to enroll on the trial. But asymptomatic disease progression in the brain should not be an exclusion criteria. And that is true about ALK trials. But, ALK patients need to go on other lung cancer trials. And I would say that patient advocacy group, not just the ALK group, but in collaboration with others, really need to push our industry partners to allow those patients.
Thank you, panel. A couple of notes I took it to summarize. One is that surveillance brain MRI, you should be having it. And the panel says 6 to 12 months, and that should be as important as the other things in your journey. Again, it came out again, the art of practicing medicine for ALK patients is highly specialized. And so while you can get good care locally, if you have a recurrence, you need to come back to a specialized center for that full evaluation. That's in everybody's best interest, right? Especially yours. Next, the location of where the brain mets are matters. And so that's why when you talk to someone and they got a different treatment for theirs than you did, there are a lot of good reasons for it. It's not just the physician's choice, but it could be just where it is and the number and there's a whole lot of factors that need to be considered by a group that are experienced in ALK brain tumors. And then and Jess also made the point about the time between new lesions matters, and it affects the thinking about whether it's a local or a systemic therapy. So those are just a few of the take-home messages that I wrote down. Hopefully you got those and more. So let's go to the last case. Now we're going to talk about oligometastatic progression. And I think you may find that there's a lot of different opinions on what it is and how it's treated, not just amongst this group, but in general in thoracic oncologists. That's why I'm glad we're discussing it. So now we have a younger person, right-sided chest pain and cough for a month. Last thing they thought they had was lung cancer, but they went in and the mass with lymphadenopathy and a liver lesion, so stage 4, biopsy adenocarcinoma, no intracranial disease in this case. They had the usual EML4 and they went on an FDA approved TKI and they had a complete response. Complete, no evidence of disease. And I know there are people in this room who are in that situation and hopefully they'll always be in it. Several years later, 2 lesions were identified on routine scanning. One in the lung and one in the bone. A lesion biopsied and it was the same lung adenocarcinoma. The molecular testing had no change from the original analysis. 2 lesions only. I don't know the interval. We can all speculate how that affects our thinking, but Vincent and Angel are going to start the discussion on this one.
Thanks, Ken. I guess I want to highlight the premise and the concept that this case is illustrating, which is the fact that what we try to do is to keep our patients on their TKI as long as possible, assuming that they're tolerating the TKI well and that they've derived good clinical benefit from it. And that sort of touches upon the question of, well, how long has it been since they've been on this TKI before, the oligoprogressive lesions have popped up. And we have data to show that this sort of approach really does improve survival and that it potentially keeps options open for the subsequent lines of therapy. Now, the big question really is how many is too many in terms of oligo progression. In this case, it's 2 lesions. I think many of us would probably find that to be reasonable in terms of trying to, for instance, zap these independent lesions with radiation or something that has that is relatively safe like that with low side effects. But there's a lot of, I guess, art, as Ken has put it, in terms of the scenarios where there are 4 lesions or maybe even more.
I think that with this scenario, just like the first one, we also want to make sure this patient has had a brain MRI, because obviously, as we talked about with the last scenario, intracranial progression is a very different story than I think extracranial progression. So I think assuming that this patient's MRI is clean, I would agree with Vincent that I think doing localized therapy to the 2 separate lesions and continue on the current ALK-TKI is very reasonable and with close follow-up, because as just alluded to earlier, I think the interval at which subsequent lesions develop will very much impact whether or not we decide to continue this more cherry picking approach versus switching them to a different systemic therapy. And also obviously depends on what ALK-TKI they're on now. I think to the question of how many lesions is too many lesions, like how do we define oligo? I think that's a really hotly debated topic. I've seen different perspectives on where it is oligo, right? So maybe oligo in the brain is different than oligo externally, whether or not these oligo progressive sites are causing any symptoms. I don't know that I have a set defined number for myself, but at some point when I start seeing 4 or 5 lesions and beyond, I start wondering if cherry picking is simply just making these scans look better, but we're not treating the underlying driving process, which is that there's a population of cells that are now progressing and causing problems. I think that based on our clinical practice, some of my colleagues may disagree, and we all have stories of the one person that did incredibly well with that kind of strategy. But I think when it gets beyond, I think 4 or 5, I really don't know if that's oligo or just the beginning of more systemic progression.
I think it's important to sort of think of the concept that we are approaching such patients. So the thought process here is that in a couple of areas, this is the same cancer as before, but in a couple of areas of the cancer, there has been some change that has allowed in those areas the cancer to outgrow the treatment that the patient is on. But in the other areas of the cancer is still sensitive. And so the hope is that you do radiation or surgery occasionally, and then continue the TKI, hoping that you're going to get a good amount of control or good period of control. The reason that number, there is a really sort of no consensus, but generally the more the lesions, when you start getting 4 or 5, the likelihood that it is also growing in areas which are not growing right now on the scans, but are likely to grow in a relatively short period of time is higher. So I think it's a judgment by the physician. How likely is the patient going to need a change in therapy? So if I radiated the patient today, but in 2-3 months, I'm going to need to switch to a different treatment, then the radiation now has not been of that much value to the patient. But if I do radiation now and the patient doesn't need a change in systemic therapy for a year and a half, then that is valuable. So I think it is important to note what is the sense. And that also plays into the duration. Here it says several years. So if somebody had 2 new lesions within 6 months of starting an ALK TKI, I would be a lot more inclined to look for switching treatments, whereas somebody who's been on 2-3 years and then has 2 lesions. So those things are important.
So these are the sort of the 5 guiding principles I have in no specific order. 1, what are my other systemic options? 2, the number of lesions. 3, the interval. 4, I talk to my radiation oncologist and say, what's the morbidity of this radiation? What's the feasibility? And I think the 5th is the patient preference, because many times we have a shared decision-making discussion where some patients are very content with their current LTKI and would like to extend that, and other ones are maybe more eager to change to the next TKI or next line of therapy.
Yeah, I think it's a really great point. So I think we should also add tolerability of the existing medication also, right? So obviously going several years on a single TKI, the tolerability is good, or at least the assumption is that the tolerability is good. So for oligomet, I mean, we have data, right? We might not have data in every single scenario, but there are published randomized studies and oligomet in lung cancer in general, again, not specifically molecularly driven tumors, but we have data for up to 5 sites of metastases being radiated or offer surgery. So there is some level of clinical data to gauge or to guide us as to what we call oligo versus none. But all of the points that my colleagues have made come into play. So for me, it also is important to know how many other lines of therapy do I have that can be very effective. Am I at a place where I really have to get as much out of the existing treatment as I possibly can? So I think that a lot of that, and as you said, patient preference, because we definitely have patients who do not want to have radiation for a variety of reasons or might not be able to get it. So I think it's, as Shirish was trying to point out, the thought process behind it is a little bit more than, okay, I have 2 lesions, I'm going to go radiate. You just have to think about what your next step is going to be, what's going to come next. So I think these are important considerations in this.
Just a point to add to Tom's 5-pointer. On the 4th point of the radiation oncology consultation, I think often you'll find that if you ask, a surgeon, or if you ask a radiation doctor, could you do surgery? Could you do radiation? The answer might be yes, but that doesn't mean that it's the right way to go, right? So that's where, again, that multidisciplinary true communication between your doctor, the medical oncologist, and the radiation oncologist and, interventional radiologist is really important. For example, for the lung spot, if it's a peripheral kind of around the edge of the lung that's relatively small, where you can do a quick course of really truly ablative radiation therapy, that's very much appealing. But if it's in a central location, very large, where what's required is a long multiple-week course of daily radiation, and you're having to hold your ALK inhibitor that's otherwise doing a really good job for your cancer for that long, that's a very different calculus right there in terms of the possible risks and benefits. So again, really going back to not just what, the fact that we're seeing a lung spot and a bone spot, but what is that lung spot? Where is it? What's the size? And where is that bone spot? And what are the options in terms of the local therapy while having to hold a TKI?
I just wanted to highlight what I think is a really important point that both Tom and Hoss made. When we talk about, and not even just within ALK, but just in lung cancer in general and other cancers, when we talk about an oligometastatic progression paradigm, the important thing in my mind really in amongst the 5 that Tom noted was, what are my other systemic options? Because your ability to ensure sort of a longer runway for that patient on the same TKI is impacted by whether or not you may actually have a better treatment that may be more compelling. As sort of a hypothetical example, although we actually do still have quite a few patients still on crizotinib. For instance, if you've been on crizotinib for a long time and then you have even just 2 or maybe even just 1 site of metastasis in the bone, if you follow the algorithm, it makes a lot of sense to go ahead and maybe just radiate that. But it also could be quite reasonable to say, this is actually potentially a good time to actually switch our TKI to a brain penetrant one that we know has, greater potency. And is also likely equally well tolerated. So it really is a consideration of what else you have left in the toolbox. So the considerations are much different for somebody who may be on lorlatinib. And then you may actually be more than inclined to do SRS to 12 lesions in the brain. That's not common, but it's not unreasonable, I don't think, in the right situation. So good news is Chat, GPT, and AI won't take our jobs quite yet. But it'll be soon.
Sure. Just want to finish up. I know, Ken, you have to wrap up, but it's important to note here that there was no resistance mechanism detected. There are situations where you find the resistance mechanism and you have oligometastatic disease. And what do you do there? Do you add the targeted therapy or do the local treatment? And what I've used is I've used the liquid biopsy in that situation. So if the liquid biopsy is positive, my sense is there's more disease, because generally for liquid biopsy to be positive, not that 2 lesions cannot shed enough DNA that liquid biopsy would be positive. But what I've done generally in that situation is added the targeted therapy to the resistance mechanism, seen what happens, ensured that there was a good response, and maybe at that time come in with the local treatment. So it is, you do need to take into account whether a resistance mechanism was identified or not.
So Tom, everybody wants to know your 5. Can you say your 5 again? So everybody's got your pen out? Okay.
Under pressure here. So I think the first one, what are the systemic options? Second one was the number of lesions. The third is the pace or the interval between the progressions. The fourth, which Jess, I think, articulated much better than I did, what is the risk and the feasibility of the radiation? And I again emphasize that I'm in clinic with radiation oncologists, and we kind of, are a very tight team. So that helps me with that decision. And I think the fifth is the shared decision-making, which I think Hoss hit on with the tolerability of the drugs, where if someone's tolerating the drug, you're a little bit more inclined to sort of try and continue the long runway, as Vincent said. And I think those are sort of the key principles here. And I think all of us have sort of intuited that there's not like a one answer for everyone. And so this is, again, one of the more nuanced discussions that we have with our patients.
Well, all my other sessions have been exactly on time today. But I'm going to go over slightly with this group because Tom said something, and if everybody could just give us your brief answer. Tom said, we do shared decision-making with our patients. So my question is, what does a patient need to know to be able to be a shared decision maker?
Since I opened the can of worms, I'll take the first. I think one of the challenges we all face is there are varying degrees of education. I have patients who know more about ALK-positive lung cancer than I do, and they're very informed. And what we try and do is I go through all the options. I like to write them out and give the pros and the cons. And this takes time. And then if there's a moment of hesitancy or indecision, I say, why don't you come back in a week or two? Because sometimes you have to let the dust settle, because there's a lot of information overload in these situations. I think people probably retain about a third of what was said in those visits. And so I think the critical concept is time. You really have, if you're serious about doing shared decision-making, I mean, it's a time process.
So I agree with time, and obviously a well-informed patient and family and caregivers are really important. But the other thing that I tend to encourage is second opinions or third opinions. Go out, talk to others. I might not have a trial or might not have access to a study, but you go someplace else, there might be another option that you hear that might be better for you, or you might want to do that. So don't be shy about saying, thanks, you've been with me for 5 years, but I'm going to go get a second opinion. I don't think any of us are going to be offended by that. And to be very open and frank and with all of you, often I call these people and I say, hey, what would you do next? So it's like we have an informal second opinion among ourselves anyway. So don't be shy about that. So I think that goes into the shared decision-making process.
So I think I agree that obviously, I always tell my patients, I think my role as their doctor is to provide them with the information so that they feel empowered to make the decision that they think is best for themselves. And I agree that there are definitely patients that come to me with New England Journal of Medicine publications that I haven't read, NCCN guidelines, I've gotten it all. But we also obviously see the other spectrum, right? When patients just simply say, what do you think is best, right? And I think that is our job as a doctor, that we should put to our patients what we truly believe is the right decision in this difficult time, right? We're talking about progression. We're talking about cancer. This is a really emotionally charged time. And sometimes patients like, you're telling me too much. I would like to know what your opinion is on this and why you think that is. And I think that's okay, right? I don't think we're being paternalistic in that manner. I think we're being helpful. That's what all their training is to do. But I agree, having, I text people all the time, like, oh my gosh, I have this, what would you do? And so then at least I also feel good that in this difficult situation, at least one other colleague agrees with me that my idea isn't completely, unreasonable or out of the box. But I think, to Haas's point, second and third opinions when you're making this difficult decision is really helpful.
I think what I find helpful is to try to convey as best as I can that I'm not discounting their opinion and their proposals or their thoughts about how to best proceed next. That's a really important point of shared decision, so that your patient feels that they are being heard and that you are able to help with whatever additional insight or information that they may need on their end. So really, I would throw it back to you, Ken, and I would say we should ask the patient, what else do you need to help make this decision?
Just add that, most patients want to know what treatment is going to give me the best chance of beating the cancer or keeping the cancer controlled for years together. I think when it comes to ALK, more than other lung cancers, I feel there is an element of what is best for them in their life at that particular time. It is not always about what is the best thing to treat a scan, but what is the best thing. So it is, the shared decision meeting is not just about what is best for the cancer or what is the best to treat the cancer. It is what is best true. So the shared decision meeting is not just about explaining what the doctor feels is the best next option, but ensuring that that meets that patient's needs at that particular time.
Well, that sounds like a great place to call. We couldn't ask for a better group, could we? Yeah. No. All right. Where's our buddy Dan with our instructions? Sorry for taking 10 more minutes. We couldn't miss the opportunity.
If there was ever a buffer to be built in, it would be built in for this session. So another round of applause. I just want to say, this group took time away from their families. They dedicate their lives, all their hard work to our community and keeping us, top of mind when they're doing their research and when they're seeing their patients. And for them to take their weekend and spend it with us as opposed to their families is just another testament to, how truly awesome they are. So, we can't thank you guys enough, and you guys are welcome back anytime. Thank you so much.